PPE, standard and isolation. So a couple equipment for PPE. Standard PPE consists of hand hygiene and gloves if encountering patient secretions, droplet hand hygiene gloves, mask, and eye shield, contact hand hygiene gloves, gown, airborne hand hygiene gloves, gown, fit tested N95, respirator. This one you want to look out for like TB or COVID. A couple instructions. You're always going to provide hand hygiene first, then glove up, and then droplet hand hygiene, apply simple mask, eye shield, gloves, contact hand hygiene, gown up, then gloves, airborne hand hygiene, gown, don fit tested N95, gloves. Cylinders, so indications, hypoxia of patient or needing more O2, considerations, why is the patient hypoxic, acidosis versus alkalosis, what does it provide the patient with high quality O2 to help them ventilate, the outcomes usually to improve O2 saturation. So some of the equipment is the H cylinders, which are the big cylinders, and E cylinders, which are the common small hospital cylinders. The duration of flow formula, cylinder pressure times cylinder factor divided by flow rate, which is in liters per minute, equals your duration. Peak flow meter. So the technique is have patient take a deep breath in and then blow out as fast and as hard as possible. Frequency usually done after each lung treatment or as wanted to track lung function. Ranges are determined based on age and height of patient. The green zone is 180% of the expected result. 50 to 80% of expected is yellow zone, and the red is if you're less than 50% of expected peak flow. Indications, testing for peak flow, either bedside or PFT test. And this would be if somebody had COPD or asthma. A couple considerations is, does the patient have proper understanding of how to perform the test? Very important for the peak flow test. And a couple outcomes is to monitor peak flow before and after lung treatment to track if treatment is working to improve lung compliance. EG, or also known as arterial blood gas. Indications when trying to determine O2, CO2, or pH, dealing with pulmonary disease, ARDS, shock, or diabetic ketoacidosis. Considerations you'd want to think of is, does the patient have proper blood flow to the hand if you injure the artery? Perform modified Allen's test before sticking radial artery. What does it do? It gives you a detailed amounts of O2, CO2, pH, and bicarbonate, among other gases in the blood. Useful to know so clinician can make better judgments about treatment or diagnosing diseases. Measurements, normal pH 7.35 to 7.45. PCO2 is 35 to 45, and then PO2 is 80 to 100. Is acidotic if pH is less than 7.35 and alkalotic if pH is greater than 7.45. Oximeter. Indications when you need to monitor the SpO2 of a patient. Considerations will not work for patients with dark nail polish and SpO2 may not be correct. What does it do? It uses infrared light to monitor oxygen bound to hemoglobin. Measurements, normal measurements are 93 to 99%. Abnormal is anything less than 93% saturation. There are two main different types of pulse ox. The one to the right, which you place on the patient's finger and then take off. The other being a strip of adhesive that has a monitor in the tip that is placed on the patient's finger. It can be left on for extended amounts of time and connected to a monitor to constantly monitor over periods of time. Cannula, indicated for use if SpO2 is less than 92%. One thing that needs to be considered is if the patient is going to need humidity with their O2 therapy, which is 4 to 6 liters. This provides a direct flow of O2 to the lungs. 0.25 to 6 liters, and you start humidity at 4 liters per minute. So recommendations, 0.2 FiO 1 liter per minute, 0.24 FiO2, add 0.04% for every liter per minute added. A couple hazards of nasal cannula include drying of the nares or incorrect placement leading to oxygen not making it to the lungs. AEM. So indications for an AEM are hypoxemia requiring precise FiO2 delivery, COPD patients needing controlled oxygen therapy, post-operative patients with moderate oxygen needs. A couple considerations are to ensure proper fit to prevent room air entrainment errors, monitor patient for comfort and skin integrity. A couple instructions: explain to patient how to wear the mask properly for one, position mask securely over the nose and mouth, attach tubing to oxygen source, and adjust flow rate to achieve prescribed FiO2. The outcomes you're hoping for are improved oxygenation with controlled FiO2, prevention of hypoxemia without causing hyperoxia, and stable SpO2 levels during therapy. The formula: FiO2 percent equals 21 plus oxygen flow liters per minute times 4 for standard AEM approximate. Dose inhaler, or known as MDI. Indications for use would be bronchospasm and asthma or COPD. Considerations could be proper coordination between actuation and inhalation, or use of a spacer for holding chamber if patient has difficulty. Instructions are: shake the inhaler well before use, exhale completely before placing mouthpiece in mouth, actuate the inhaler while inhaling slowly and deeply, hold breath for 5 to 10 seconds after inhalation, exhale slowly and rinse mouth if using corticosteroids to avoid oral thrush. Some outcomes are to improve bronchodilation and airflow. Technique: proper hand-breath coordination or use of holding chamber. Maintain upright posture during inhalation. Ensure correct number of puffs and timing as prescribed. COPD and asthma patients benefit greatly. Or known as dry powder inhaler. Indications: management of asthma and COPD. A couple considerations: require sufficient inspiratory effort to properly aerosolize medication, and the patient must be able to coordinate inhalation with device activation if applicable. How it works: medication is in a dry powder form, and then the patient inhales rapidly and deeply through the mouthpiece. Inspiratory flow disperses the powder into fine particles for pulmonary deposition. The outcomes: improved airway patency and lung function. The technique: exhale fully before inhalation, place mouthpiece in mouth and seal lips tightly. Inhale forcefully and deeply to draw powder into lungs. Hold breath for 5 to 10 seconds and exhale slowly. Rinse mouth if corticosteroid medication is used. Patients, again, with asthma and COPD benefit greatly. The N, or known as small volume nebulizers. So indications for use is management of acute bronchospasm and asthma or COPD. Considerations: requires access to compressed gas or air source. Patient must be able to tolerate mask or mouthpiece. And the treatment time may be longer compared to MDI or DPI. The instructions: assemble nebulizer with prescribed medication, connect to air or oxygen source, instruct patient to breathe normally through mouthpiece or mask, continue treatment until medication is fully aerosolized, usually 10 to 15 minutes. Outcomes: rapid delivery of bronchodilators or corticosteroids, so rapid improvement. Technique: ensure patient is seated upright, check connections and nebulizer function, encourage slow deep breaths with occasional breath holds, and rinse mouth for corticosteroid therapy. Again, patients with acute exacerbations of asthma or COPD benefit greatly. Rebreather and non-rebreather mask. Indications would be a patient needing higher percent FiO2 than nasal cannulas can give. And then one consideration of this device is if the one-way valves are open while you're using it, making it either a partial rebreather or a non-rebreather. It creates a reservoir of high percentage FiO2 for patient to be able to breathe. Outcomes: to increase patient SpO2 by getting a higher FiO2 inhaled. Partial versus non-rebreather mask. Partial rebreather mask flow range from 6 to 10 liters per minute. They range FiO2s from 40 to 70%. And then the flow range for the non-rebreather is 10 to 15 liters with an FiO2 range of 60 to 80%, up to 90% with tight seal and high flow. And yeah, that's it for the mask. And simple mask. So simple mask indication is mild to moderate hypoxemia, short-term O2 therapy. Contraindications, avoid flow of less than 5 liters per minute because of CO2 retention risk. Mechanism mixes O2 with room air through side ports. Flow range of FiO2 is 5 to 10 liters per minute, so 35 to 55%. Technique, apply over mouth and nose, start flow before use. Outcome, improve oxygenation and SpO2. Beneficiaries, patients with moderate hypoxemia. Then an aerosolized nebulizer mask. Indications, humidified gas or aerosolized medication delivery. Contraindications or considerations, poor fit or leaks reduce drug delivery. The mechanism uses compressed air, O2, to convert liquid medications to fine mist. Flow range, particle size, 6 to 10 liters per minute, 1 to 5 micrograms aerosol for lower airway deposition. Technique, add med to nebulizer, connect tubing, maintain upright position. Outcome, medication reaches lower airways, improving airflow and secretion clearance, and the beneficiaries are patients with asthma, COPD, or airway inflammation patients. High-flow nasal cannula, indication ARDS, low SpO2, or any disease requiring higher flow O2. Contraindications, facial trauma, nasal obstructions, or hemodynamic instability. How it works is it provides high-flow variable FiO2 through heated humidified process to patient. The measurements usually runs at 20 to 80 liters per minute. Hazards can be if an airway and respiratory discomfort, overtaking O2 respiratory drive. Flow rates range from 20 to 60 liters per minute, FiO2 21 to 100%. Patients suffering from ARDS, pneumonia, and those with obstructive sleep apnea are who benefit the most. Incentive spirometer. Indications, prevention or treatment of atelectasis. Contraindications, vital capacity less than 10 milliliters per kilogram or inability to take deep breaths. How it works, encourage slow, deep inspirations to inflate alveoli, increase transpulmonary pressure and inspiratory volume, promotes lung expansion and improves gas exchange. Measurements inspiratory capacity in milliliters or liters compared to predicted values or set goals. Instructions to the patient, sit upright in Fowler's position, exhale normally, place mouthpiece and inhale slowly and deeply. Hold breath for 3 to 5 seconds and then exhale normally. Repeat 10 times every hour while awake. Who benefits? Post-surgical patients, those with atelectasis or at risk of, and patients with restricted mobility or neuromuscular weakness. PPB, considerations for use, assess patient ability to cooperate and trigger breaths, use with caution in pneumothorax, hemoptysis, or high ICP, monitor for hyperventilation, barotrauma, or gastric distension. How it works, delivers positive pressure during inspiration to assist lung expansion. It increases tidal volumes and alveolar ventilation. Expected measurements are increased tidal volumes, improved inspiratory capacity, decreased respiratory rates, and improved breath sounds and oxygen saturations. Who benefits? Postoperative patients with atelectasis, COPD patients needing lung expansion support, and neuromuscular weakness. The three main controls: pressure limit sets the maximum inspiratory pressure, flow rate controls speed of inspiration, and sensitivity adjusts trigger effect. Typical settings: pressure 10 to 15, sensitivity 1 to 2, and flow rate is adjusted for a 1 to 2 inspiratory to expiratory ratio and patient comfort. T. High frequency chest wall, auscultation, percussion, and PEP. Indications and considerations for use. Indications: retained secretion, cystic fibrosis, bronchiectasis, atelectasis, neuromuscular weakness. Considerations: assess patient tolerance, stability, and contraindications, for example, rib fractures, recent surgery, hemoptysis. How they work: high frequency chest wall oscillation. Inflatable vest delivers rapid chest compressions to loosen mucus. Percussion is manual or mechanical clapping of the chest wall to dislodge secretions. PEP, positive expiratory pressure. Patient exhales against resistance. Back pressure keeps the airways open and moves secretions from small to larger airways. In the outcomes, you're looking for increased sputum production and clearance, improved breath sounds, oxygenations, and ventilation. For technique, HFCWO, 10 to 20 minute sessions, percussion, 3 to 5 minutes per segment, PEP, exhale actively, not forcefully, through device, 10 to 20 breaths per cycle. And nasotracheal suctioning. Some indications for this are visible or audible secretions in the airway, decreased oxygen saturation or increased work of breathing, ineffective cough or inability to clear secretions. Considerations: assess patient's oxygenation before and after the procedure. And the technique: assemble equipment, set suction pressure. In adults, you want 100 to 120 millimeters of mercury. And in children, you want 80 to 100 millimeters of mercury. Then you insert catheter. Apply suction while withdrawing the catheter in rotating motion. Oxygenate and monitor between passes. Hazards and complications: hypoxemia, bradycardia or arrhythmias, mucosal trauma or bleeding, infections, and/or atelectasis. So suctioning continued. So how it works is negative pressure removes secretions from upper airway or trachea. It improves airflow, ventilation, and oxygenation, and reduces the risk of airway obstruction and infection. The outcome is improved breath sounds, increased SpO2, and decreased work of breathing, clear out patient airway. Oral and nasopharyngeal airways. So indications are going to be airway obstructions from tongue or soft tissues. Considerations are going to be choose correct size and type. Are they unconscious or conscious? How it works is OPA holds the tongue away from the posterior pharyngeal wall, and an MPA provides air passage through the nose into the pharynx. Outcomes: improved airway patency, easier bag mask ventilation or suctioning, improved oxygenation and ventilation. Technique: OPA, select size, insert upside down, then rotate 180 degrees to use tongue depressor. Confirm placement, should rest on lips. MPA, select size, nose tip to earlobe, lubricate and insert in a nostril, and advance gently along nasal floor. Hazards and complications: gagging or vomiting, OPA, nasal bleeding or trauma, MPA, airway obstruction if too small or misplaced, and laryngospasms or aspirations if inserted incorrectly. Indications: airway protection in patients with decreased consciousness, respiratory failure requiring mechanical ventilation, airway obstruction or impending obstruction, facilitation of suctioning in patients with copious secretions. Considerations: you want correct size selection based on patient age and size, and proper placement. You get that through confirmation by ETCO2, chest rise, auscultation. How it works is provides secure airway for oxygen and ventilation, allows for positive pressure ventilation. Outcome: improved oxygenation and ventilation. In technique, you want to pre-oxygenate the patient, use the laryngoscope to visualize vocal cords, insert ET tube through vocal cords to appropriate depth, and then inflate cuff to confirm placement. A couple hazards you want to look out for are trauma to teeth, vocal cords, or airway, incorrect placement, esophageal intubation. And who benefits are critically ill patients requiring airway protection. Electrocardiogram. So indications, monitoring heart rhythm in patients with suspected arrhythmia, as evaluation of chest pain or myocardial ischemia, preoperative assessment in high-risk patients. Some considerations you want to take in are skin should be clean, dry, and free of oils or lotions. Avoid placing electrodes over bony prominences or scars. Instructions include explain the procedure to the patient, ensure patient is relaxed and lying still, place electrodes according to standard 12-lead ECG placement, instruct patient to breathe normally to avoid talking during recording. Measurements, heart rate and rhythm, PR, QRS, and QT intervals, ST segment changes, axis deviations. And then the setup is connect ECG machine and ensure proper calibration, attach electrodes to correct anatomical locations, and verify good signal quality on the monitor before recording. And who benefits are patients with suspected or known cardiac conditions, critically ill patients requiring continuous cardiac monitoring, or patients undergoing diagnostic evaluation for chest pain, syncope, or palpitations.